Hello and welcome to another episode of the Tinnitus Matters podcast, where we discuss all things tinnitus. I'm Phil Holmes.
And I'm Christine Nixon. And with us today, we have a very special guest
Yeah.
who's come from Lancashire Teaching Hospitals, NHS Trust. It's Mr. Rajeev Advani, who is a consultant in ENT and a surgeon there with a specialist interest in tinnitus. Welcome and thanks so much for coming today, Rajeev.
Thank you very much, Christina, and thank you both for having me here. It's a real pleasure to be able to speak about tinnitus.
No, it's great that we've got you here, and the knowledge, hopefully, that you're going to pass to us and the listeners is great.
Yeah, it is. So I think we should dive straight in,
Let's.
really. So when a patient's referred to ENT for a tinnitus issue, what typically prompts that?
Yeah, I think it's the big thing that prompts referrals and the big thing that are on patients' minds are, do they have a brain tumor?
Right.
So that is probably the most the most common reason for referral. And if you ask patients, which I do, because they essentially some of them would like a scan, but if you ask them directly, are you concerned about something? They'll say no, and then when you tell them, all right, well, are you concerned that you may have a brain tumor, and do you want a scan because of this? Then they often say yes.
Okay.
So I think the single largest reason is people are concerned that this tinnitus may be representative of a brain tumor.
Rajeev, can I just ask that? Why do they say no initially? What do you think the psychological reasoning behind that is?
Yeah, I think you don't want to come across as a hypochondriac,
Ah, I see, yeah.
right? You're a patient, you're a layman, you may or may not be medically
Yeah.
trained.
Yeah.
You don't want to culturally, you don't want to ask that. Okay, I need to have an MRI scan because I'm concerned that I have a brain tumor. You don't want to come across as a hypochondriac, so you kind of like dumb
Play
it
it down.
down until somebody brings it up. And equally, when I examine patients in ENT for other reasons outside of tinnitus, and I know that their concern is they may have cancer, what I tell them is, you do or you do not have cancer, rather than telling them, oh, it could be this, it could be that. So even if they've come in for example, a hoarse voice, I know in the back of their mind they're thinking, do I have cancer? So I said, look, there's no signs of cancer.
But how can you definitely say they do or don't without further tests?
If with clinical examination, you can more or less tell.
That's amazing, isn't it?
But yeah, so it's interesting. I think after years of practice,
Yeah.
I've basically
Fantastic.
honed down my skills to try to figure out what patients are here for and what they really, really want to know. And for tinnitus, the main thing they want to know is, do I have a brain tumor?
So in terms of that first appointment with the ENT, so they get referred and they come through, what happens in that appointment that would differ from the GP's initial consultation? So the difference between the GP and the ENT first appointment.
Sure. So when they see an ENT specialist, before they see the ENT doctor, they will often have a hearing test and a pressure test on the eardrum.
Right.
And we can discuss about this in more depth, about why this is important. And then they'll see the ENT doctor, who will ask them about other symptoms. So there's other causes, or organic causes, or physical causes that can cause tinnitus. So the specialist should ask about these things. The specialist should also examine the patient. And I'll give you an example of what an examination for tinnitus may involve. So it will involve looking at the ears, but often you don't see anything. So
Right.
as in, when I say you don't see anything, it looks normal. So there's no abnormal appearances.
Okay.
And actually, aside from a handful of times, I have not come across an abnormal appearance when looking in the ear. There are some exceptions, and this is why you would see an ENT specialist. If somebody has tinnitus where you feel as though your heart is beating in your ear,
Yes.
so it's called pulse-style tinnitus.
Yes.
One of the things a specialist is looking for is a little red tinge on your eardrum.
Right.
And it's called a rising sun appearance. And this is something that GP may not be able to pick up, but a specialist should pick up. and that is evidence of something called a glomus tumor. And what a glomus tumor is, it's a blood vessel type tumor, which is in the ear, which can cause the heart beating in your ear.
Right.
So it causes the pulsatile tinnitus.
Can I just ask you, Rajeev, what percentage, how often would you see that clinically in your clinics?
Very rarely.
Right.
Very rarely. You have lots of primary care referrals from GPs with tinnitus stating that it's unilateral, which means one-sided. It may state that it's pulsatile or non-pulsatile. But the finding of the rising sun appearance, the red tinge on the eardrum, is very, very rare.
So that's reassuring, isn't it?
But it also kind of underlines the fact that it could be that, and therefore you do need
It's
to be seen
important, yeah.
straight away. And then once that's ruled out, other kind of mechanisms and treatments for tinnitus can be kind of
Absolutely, yeah, absolutely. So there, as I was saying, there are real pathologies, real problems that can cause tinnitus. Another thing that a specialist may pick up on a clinical examination is if the patient has eye movements that are not how do I put it, are not smooth.
Yes.
So the hearing nerve runs with another type of nerve, which is a balance nerve. So it's very near to a balance nerve. And if there's something compressing the hearing nerve, such as a brain tumor of some sort, it can also compress the balance nerve.
Yep.
And if it does that, then you may have eye movements when you look left and right that are not smooth, and they kind of go back and forth.
Flicker, kind of.
Flicker, yeah. So it's called nystagmus in clinical terms. But yeah, so you're looking for that as well. The other nerve that sometimes runs with the same nerve that causes hearing and balance is the nerve that gives you movements of your face.
Right.
It's so delicate around there, isn't it? All the different nerves. That
Yeah,
you're looking for that
absolutely.
are
So it's a
impacted.
tight area with all these different things going on. And
So when someone walks in, you're immediately, aren't you, looking at everything really, I suppose, and
absolutely. So if somebody comes in and they're being referred at as a one-liner from a referring doctor, this patient has tinnitus, and they walk in, they're unsteady, I can see that their eyes are flickering or they have a facial droop, I am immediately concerned that this is something
Yes.
something more serious that's happening.
but that's very rare.
That is very rare.
Yeah. But it's always important you go to your GP, you get referred in, and a doctor highly specialised like you can make that assessment and judgment. And so, and now I'm curious to know, Rajeev, where do you go? So if there's a problem, what happens? And then if there isn't, what do you do in your clinics?
So just to clarify that question, do you mean if somebody comes in and their clinical examination is normal versus abnormal? Is that what you mean?
Yeah.
Okay. So if I was to see a patient and for whatever reason I suspected that there was a pathological problem of this tinnitus, then you would have to do further tests. And this often involves scans.
Yep.
If the examination is completely normal and the hearing is normal, then you can't really do much about it. So you don't need to do any further tests. But you do have a detailed discussion with the patient that, you have tinnitus. It's a symptom. What I tell them is there is no medicine that can treat it. There's no surgery that can cure it. But one thing that we do have is called tinnitus retraining therapy. And that's more or less the only thing that can treat patients like that.
But it's quite a successful treatment, isn't it, for some patients?
It is, yes. Yes. In
helping
patients,
them.
yeah, absolutely. In patients where it's very intrusive, in patients who are suffering a lot from the symptom of tinnitus, yeah, it's very, very good.
Oh, and can you just explain what that therapy entails for our listeners?
It may be hearing aids, it may be sound generator therapy and counselling and so forth.
If someone's hearing is reduced, there's good research to say that improving the hearing by whatever means, such as a hearing aid, or if there's for example, one of the small bones of hearing has disappeared and it needs to be reconstructed, there's good research that shows that improving the hearing also improves the tinnitus.
Yes.
Yeah, so that's a valid
A
treatment
go-to.
option.
Yeah, that's good.
And similarly, if you're hard of hearing due to age or noise exposure and you have a hearing aid, that should also improve your tinnitus. On the psychological aspects, I know you're going to have an expert on this who's going to speak to you in another episode. But there, like anything in healthcare, it's known as a biopsychosocial model, which means that there's biological aspects, but there's as in physical problems, but
Yeah.
there's also intertwined with psychological problems. But I don't think we can, for tinnitus and for most things, I don't think we can just say this is a psychological aspect or a psychological problem that can be treated with cognitive behavioral therapy alone. I know it's difficult to diagnose and get to the bottom of tinnitus, and often we don't. So there may be a psychological component to it, but I don't think it's purely driven by psychology.
Interesting.
And then going forward to the research, I recently had a conversation with a really, really good doctor who is an ear specialist, and I asked him about the different research that's ongoing. And as far as we're aware, there's not much that's currently ongoing. I was in the past involved in a study where the study design was to provide steroid injections into the ear for tinnitus.
I was going to say specifically for tinnitus.
For tinnitus, yeah. And on one group, you had patients having steroid injections. On the other group, you had patients having a placebo injection.
Yes.
And soon that study was stopped, so it didn't show any
Right.
any benefits. So unfortunately, that didn't work.
That's a shame, isn't
Yeah.
it?
Yeah.
But it's good that actively, people are out there still trying and doing trials for it.
Yeah, absolutely. It's a big problem. It's a huge cause of anxiety in patients. It's a huge cause of patients being referred in.
And like we say, there's more people than you realise, or more people. Like you were talking about your mum, weren't you, Phil? And she didn't even know she had tinnitus.
Well, she hasn't been diagnosed. But I was Rajeev last night. My mum was asking me what I was doing today, so I said I was doing these podcasts with yourself.
All right.
And she said, "Oh, what is tinnitus? What does it sound like?" And she just described to me what
Yeah.
somebody would describe tinnitus as.
Yeah.
So yeah, there's still this kind of a lot of people have it, but don't.
Yeah,
It doesn't really
help.
affect them at that point to where they'd want to have a referral or things. But
Yeah.
but yeah, it's interesting. And what's the statistic about how many people suffer from tinnitus?
So they said 1 in 7.
1 in 7. I thought it would be higher than that.
Well, that's what's noted, isn't it? That they say in the charities and the research so far, but the statistic is always changing.
Because I always tell people or patients, 70% of
Yeah.
the population will have tinnitus at some point in their life.
Yeah.
Yeah.
And I mean, the three of us are sitting around this table. I have certainly had tinnitus at some point. Have you, Phil?
I have it now, yes.
Yeah.
So with me, I think we might have touched upon this in other episodes, but I had a head injury, and after my head injury, when I came round, etc., I actually damaged my right ear, and since that point, I've got hearing loss and tinnitus in my right ear only. My left ear's.
That's what I was going to ask you. Did you also have hearing loss associated with that head injury?
Yes, I believe.
Significant, wasn't it?
For my position at the university, I teach music production, music technology, and I'm very I'm in recording studios a lot, in front of speakers, critically listening, etc., etc. And I've always looked after my ears, and I know that I was okay. I didn't see anything wrong. Or hear anything wrong, and then when I woke up after the head injury, it was like there was lots of blankets on this side of my head, and I couldn't hear. And then I went to ENT after I was discharged from hospital, and then I had the hearing test, and then so my tinnitus had come from that.
From that, yeah.
But
I'll tell you another interesting thing, Phil. So you're in the music
Yes.
field, and have you ever experienced a time where you had a significantly loud noise and you suddenly found your hearing dropped and you had a screeching ring in your ears.
Many years ago when I used to gig, yes.
Yeah. So that, I think, Christine may say that is not correct, but I think that's a good example, because when you have a significant noise, you can have something called a temporary threshold shift.
Yep.
What that means is your hearing suddenly drops because your ear is traumatized by this loud noise. And then you get this ringing tinnitus. So that's further evidence that when your hearing drops, tinnitus can be precipitated. And then the temporary threshold shift corrects itself, and I don't know if the tinnitus goes or not, but it does correct itself. That's why it's called temporary.
Yes. Yeah.
I know we've discussed this, haven't we, before? And then the concern is that some of your hearing goes each time.
Yeah,
Would
that's
you
true.
say that's correct?
That is true, yeah.
Yes.
So, studies have shown that having repeated trauma, to make it sound simple, your ear has little cells that look like hairs. They call hair cells.
Yep.
And those get damaged with every noise trauma.
Exposure.
So absolutely,
So
yeah.
protection is important.
Absolutely. So when I'm seeing a patient, the first thing I ask them is, after introducing myself, I said, "Hi, nice to meet you. How old are you, and what do you do for work?" And sometimes people may be thinking, "Why am I asking this question?
Yeah.
Like, is he trying to see, where my socioeconomic status is or whatever?"
Or is
But-
it just friendly? Or,
Yeah, but really, I'm trying to see about your risk factors. So I want to know if you've had occupational noise exposure.
Yes.
Right, so when somebody with tinnitus comes in and I ask them that, if he says he's a bricklayer or operates heavy machinery, I already kind of have in my mind, what could be potentially going on.
Yeah. Dentists as well, as we talked about before on an earlier episode, the sound of the drill for dentists.
Yeah.
That can sometimes affect dentists. So just as a patient that comes to ENT,
Sure.
what advice would you have to anybody listening? What questions should they be asking you when they come in? So if they've been referred from their GP,
Yeah.
they managed to sit down with yourself.
Yeah.
What have you got any advice for them for what they should be asking or what they should be kind of mindful of before they come in to be telling you about?
Yeah, so the questions that they should be telling, it's a two-way process,
Yes.
right? A consultation is a conversation.
Yep.
That's how I think the best consultations are. It's like a conversation where you are trying to get information from the patient, and the patient's also delivering information to you, and then you're feeding back some results. So one important thing is that you want to know if it was sudden, the symptoms, hearing loss, tinnitus, sudden onset, or if anything precipitated it. The other thing the doctor would want to know is if it has caused hearing loss.
Yep.
And perhaps the most important thing about tinnitus, which is the most common reason for referral, is if it's happening in one ear or both ears.
Yeah.
And this can be very confusing. So most people are very clear if it's happening in one ear. They say, no, it's only happening in my right ear.
Yeah.
However, if it's happening in both ears, what I've noticed by observation is that they will say, it's in my head. They won't say it's happening in
Interesting.
both ears. They'll say it's in my head, or
Yeah.
I'm not sure.
I'm not sure.
Yeah. So that's an observation I've made. And the reason for this is, in the rare occasion that you have one of these brain tumors, which are often called, the technical name is called a vestibular schwannoma or an acoustic neuroma, which is a benign brain tumor that sits on the hearing nerve.
Right.
If in the rare occasion that you have one of these, it usually causes symptoms of hearing loss and tinnitus on that side only. So not on both sides. So one of the reasons for GP referrals that you'll often see is single-sided or unilateral tinnitus.
Right.
And the whole point of that is to exclude or to ensure the patient does not have this type of brain tumor.
Let's go back to someone, one of your patients who we agree's got tinnitus. They're suffering from that, whether they've got the hearing loss or not. What is there anything that you would ask them to do at home? Any kind of lifestyle changes or exercises, or is there anything that you would get them to do or practice at home to help manage their tinnitus?
Yeah, that's a really, really good question, Phil. And I should probably have a better answer for this.
Okay.
But I essentially refer them onwards to people like Christine, who are experts in that, in managing those symptoms. But I do tell them if they have any noise exposure, they're wearing headphones a lot, loud music, going to gigs. I tell them that can make things worse.
So preventing it getting worse.
Preventing further loud audio trauma.
In terms of, I'm jumping around here now because it's as you're talking and you're saying things, I'm thinking of all these other questions.
Yeah,
and
sure.
Things. So, in terms of the age of people being referred for tinnitus, have you noticed a shift in that over time, or does it just do you seem to see a certain age group, or do you see all age groups, or is it predominant in more people, less people?
Yeah, I think we see all age groups.
For tinnitus.
For tinnitus.
Yeah.
And if it was in a child or a teenager, it would concern me a bit because they don't tend to complain of tinnitus.
Right.
So if a teenager or a child, a young person came with tinnitus, I'd be slightly more concerned.
Yes.
The elderly population don't tend to complain of tinnitus as much, and that may be because they have hearing loss and they are accustomed to it and they expect to have some tinnitus. They're wearing hearing aids. In my practice, I do see a lot of patients sort of in their 40s, 50s, who get tinnitus and are referred in.
And is that usually the occupational, i.e. they're in jobs or things where they're exposed to loud noise, or
Not always.
Oh, right,
Yeah.
okay.
So I would say less. Yeah, I think I see a lot of patients who have absolutely no occupational noise exposure, and they just develop the tinnitus. And what they say is that it's worse at night when it's quiet.
yeah,
And it's just irritating. And it doesn't really affect their life too much, some of them. Some of them, I've seen, it's usually on one or two sides of the spectrum. They have the tinnitus. It doesn't affect their life too much, but they just want to check it out. And at the back of their mind, they're thinking, okay, I just want to make sure I don't have a brain tumor.
yeah.
And then the other group who are like super, super sensitive to this tinnitus, and it's causing them complete distress. And I think in that instance, there's probably there's an equal psychological component associated with it.
Yes, I think that's a good point. And that's where maybe there needs to be more support psychologically in hospitals, doesn't there, for patients with this as well? Because it's only limited what there is out there. But as we've discussed before, there is some great tools, and that's why this podcast has been made as an information for people.
Yeah, absolutely.
alleviate.
I think there needs to be more psychological support
Yeah.
in general offered within the NHS. I won't get into the details of it, but I think it's needed.
Yeah.
What, as an ENT consultant, what percentage of the people coming through your clinics are there for tinnitus as opposed to other things?
I think if I do a general clinic, which means so I'm an ENT consultant,
Yeah.
but I have a subspecialty practice as well,
Right.
whereby a lot of other consultants refer to me for nose problems.
Right.
So I operate a lot on the nose, on the sinuses, and on the front of the brain, which is called the skull base,
Okay.
through the nose. So a lot of my practice is skewed towards that. But if I was to do a general ENT clinic, I would say in adults,
Yep.
I would say probably 20% would be tinnitus.
Because that's still quite
So
high,
that's
isn't
high.
it?
I
Yeah.
think that's high.
It's a lot. It's a lot of
Yes.
referrals for tinnitus.
And regardless, I mean, it's obviously important if it is something serious, but either way, there needs to be more support, I think.
Yes.
And do you think
Yes.
if there was more awareness, I mean, things like this podcast, but also education around it, and there was more kind of information available,
Research.
more research certainly, but if there was more information available, do you think that, I mean, this is an odd question really,
Yeah.
because you want people to come and see you to
Check they're okay.
to check they're okay.
Yeah.
But if there was more information after that,
Yeah.
that would stop repeat referrals and people coming back just to update on tinnitus, or if it gets worse, or...
I don't think you see too many people coming back.
Oh, right, okay.
Yeah, I think once they see you and you tell them everything is fine, as in they don't have a brain tumor,
Yes.
GPs don't tend to refer them back. And, you know, I rarely see them coming back, oh, my tinnitus is worse, can you do something now? Because in the initial consultation, I tell them there's no medicine or surgery that can treat it.
Yeah.
So then they end up managing it with tinnitus therapy and other things. So yeah, I don't think that's a problem. But I think that if there was more information available as to
Yes.
the
The problems where they need to be referred in,
yeah
like you're saying, and the information so the patient knew it's not one-sided, doesn't sound like a pulse. I have got it in both ears, it's a bit of a ringing, I'm okay sometimes, not others. Here are some strategies that might help me, I'll try them.
yeah
Then it calms down, and lots of people have this, and it alleviates, a lot of the anxiety. And you're right, Phil, they may not need to be referred in. And
Interesting.
they manage it themselves, and then it saves money for everyone and time.
yeah. I mean, I can see it from a patient perspective as well, where if you don't have this information to hand, you're concerned. So I think having that information as to, first of all, how common it is. So you know you're not the only person. You're not the one person in the room who may have a brain tumor. And knowing the symptoms that would make it, as Christine was saying, a little more concerning, although still the index of suspicion of something bad is quite low. If you have that information, that would be good. And I think it's also good if the GPs were educated on it.
More informed.
Yes.
Yeah, because
I agree.
it all starts there. The moment you see a doctor or a person, they need to have the confidence in making you feel at ease and giving you that diagnosis. So if the GP is not sure himself or herself, then the GP can potentially make the patient feel like, oh my gosh, this is serious, because sometimes I've seen patients with single-sided tinnitus being referred as a cancer. And
Oh, really?
Yeah, so on the NHS, there's something called a 2-week wait pathway. And what that is that if, sometimes it's called an HSC, which is highly suspicious of cancer pathway, which is certain things that if the GP thinks that you may have cancer, they're referred in urgently, super urgently,
Yeah.
and
Gosh.
the hospital has to see these patients within 2 weeks. Not long ago, in another region that I've come across in the UK, the unilateral tinnitus was on this 2-week wait pathway.
Wow.
Yeah, and then doctors would have to receive the referrals and downgrade it and say, all right, it's not actually a cancer pathway, But yeah, so it's
Knowledge is power, isn't it?
yeah,
It's
exactly.
The key here.
So if you go and see your doctor, your GP, and he says, all right, Phil, you
Yeah.
got tinnitus, I'm going to refer you on this 2-week wait pathway, and you go home and Google what this 2-week wait pathway is, you're going to be concerned,
Yeah.
Whereas actually you want the GP to tell you, all right, Phil, well, you have tinnitus in both ears.
Yeah.
The risk of something being there is very, very low. But
For a job, you're exposed to
Yeah.
loud noise, you all of those things. It's more than likely this. We will refer you,
Yeah.
but not necessarily.
Yeah,
the
but
2
yeah,
weeks.
and you can say,
And
look,
here's
it's
some
very
information.
unlikely you have a brain tumor. It's happening in both ears. There's no concerning symptoms, but yeah, maybe you need to have your hearing checked, etc., and we'll refer you in for that.
Is there anything else you'd like to say before we say thank you very much and sign off this episode?
No, that's it's fantastic to be here. So thank you for inviting me.
More than welcome. Thank you
And
for coming. We do appreciate how busy you guys are, so thank you very much indeed.
I think that was really helpful as well for everyone that's listening.
I've just learned so much more again.
Yeah, no, it's great. Thanks so much.
you are both very welcome.
Thank you.
Thank you very much indeed, and we'll be back with another episode of Tinnitus Matters very soon.